Welcome to Care Transitions Today, Case by Case, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association, where we take a fresh look at the real-world challenges of case management related to care coordination, patient transitions, utilization management, and complex discharge planning. Today, we are joined by Dr. Rebecca Severe and Dr. Sweta Singh, along with special guests Marla Kolovitz and Jennifer Dominow. Dr. Rebecca Severe is a hospital medicine certified physician serving as Medical Director of Care Management for Advocate Aurora Health. With a focus on utilization review, quality management, and program leadership, Dr. Severe is passionate about evidence-based medicine and collaborative patient care. Her expertise and commitment make her a valuable asset to the medical community and a compelling voice in the podcast. Dr. Sweta Singh, Medical Director of Case Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare make her insights invaluable to listeners eager to learn and grow in the medical field. Marla Kolovitz is the Regional Complex Case Specialist with Loyola University Medical Center. She focuses on the complex social and financial aspects of discharge planning across the region. Jennifer Dominow is the Regional Care Management and Utilization Management Director for Loyola Medicine. Jennifer plays a crucial role in the healthcare system, focusing on improving patient outcomes, optimizing resource utilization, as well as leading and managing care coordination efforts across the continuum. Whether you're a physician, case manager, or leader in case management, this season provides valuable insights to navigate complex patient transitions. This is Care Transitions Today, Case by Case. Let's begin the discussion with our first case.
I'll go ahead and get started with my case. It's a more of a UR inclined case. So we had a patient, 24-year-old, with a history of autoimmune hepatitis complicated by cirrhosis, currently on liver transplant list, status post-TIPS procedure and splenic artery embolization, portal vein thrombosis on Coumadin and Lovenox bridge, also history of ulcerative colitis, and had total colectomy and diverting ostomy done less than a month before this admission, and was complicated by ostomy wound dehiscence, for which patient presented back to the ER and had a short length of stay or observation stay 10 days before this admission, and about 5 days after the discharge of the index admission. So this admission, patient comes in for abdominal pain, wound dehiscence, and bleeding from the site. And this time put on heparin drip was, so she tried getting the bleeding control by local treatment like they've been doing before, but still no luck. It keeps oozing and bleeding intermittently. And even on heparin drip for 2 days, so they call hepatology, they call hematology, asking for recommendation. And hematology is like, patient needs anticoagulation, they'll bleed. Our only option is keep transfusing. So we are limited here. Initially, this came as a denial for level of care, but when I was doing a peer-to-peer, they said, no, it's agreed for inpatient, but what we are denying it is as a separate admission. Before I go any further, any questions on the case?
I guess just to clarify that, you're saying that you're getting the real denial was really a readmission denial, and your first day was OBS, not inpatient, correct? And the second one is inpatient, or
they
both
inpatient? They both
inpatient?
are inpatient. The first admission where patient had total colectomy and diverting ostomy was an inpatient. Then there was another admission in between that was OBS, but this admission is inpatient, and they're asking to combine it to the first admission.
Thank you for clarifying that. I was going to say that's a first for me, getting an OBS and patient, denied for readmission. Okay, that makes sense. Thank you, Sweta.
Any other clarifying questions? Would you accept this? So the rationale for combine is that this is a surgical complication and readmission because of the index surgery that happened in the index admission. And so same related issue, they always combine.
Yeah, I mean, this is going to be a hard one because I can see it from the payer's point. I mean, they're probably here because if they wouldn't have had the surgery, they wouldn't be having these bleeding issues. But there's also the underlying liver issues that this patient has. It's also driving it. I mean, I think it's going to be a hard case to win, but I definitely would go after it. I would not just, give in initially. I would do my best to really make the case that this was, not it was not a preventable admission, that, we were doing everything appropriate. You still might not get it overturned, but I do think it's worth a try. I don't know, Jennifer, do you see the same kind of thing with your payers around readmission denials, or what have you seen?
Yeah, and I think it's kind of hit or miss. I think we absolutely have to try to fight the denial, and then every case is very individual as to if they're willing to kind of bend on it, or if it withholds and stands. I would agree.
So what did you guys end up doing, Sweta? Did you go for it or not?
Yeah, so we usually try, when we get these cases, first thing we do is make sure, are we being fair in asking, is this an unrelated admission? And usually, if it is a known complication, like first readmission, if it happens within 3 days of the surgery with the bleed, is more understandable combining. This one, we did go ahead and I said to the payer provider who I was doing peer-to-peer with, this is not your usual post-surgery complication patient. This patient has had intermittent arrival to the ED, OBS admission, clinic visit, home health nurse. He stops bleeding and he starts rebleeding. So it's not something completely avoidable. 2, he's not your usual post-surgery patient because of his complex medical history. He has history of autoimmune hepatitis, so he's on tacrolimus. He's cirrhotic, so his platelets are in 30s. So he's already at that. And because of his history of portal vein thrombosis requiring anticoagulation, which hematology is like, it's a risk-benefit discussion with the patient. We can stop anticoagulation, that will stop the bleeding, but that's a risk of clotting. Which one are you willing to accept? And we were at a point like, that's what we ended up doing after 2 days, literally stopping all anticoagulation, having that conversation, give it a time for the wound to heal so it stops bleeding and close up a little bit before restarting the anticoagulation. And because of all this, it's not something which, 1, like was preventable, 2, is your usual bleeding post-surgery that we're trying to achieve the homeostasis, and 3, there are so many things like low platelet counts, anticoagulation, that's making him a more higher risk of bleeding, and even after we control it, rebleeding. So payer agreed, the provider agreed with us and agreed not combine. And especially given the complexity of this case and given the underlying, like this poor patient has 3 competing illnesses or comorbidities, that's making this case unusual.
I guess the other thing that comes to mind when I hear a story like this too, that it's more on the care management side of things versus the UM, is that, I know this patient's young and that always makes it harder, but this is a patient that is readmitting. They've got a lot of complex medical issues. I know they're on the transplant list, but are they going to actually transplant or not? I would make sure palliative's involved just to support the patient and family, not Not that they're not going to continue life-sustaining therapy at this point. They probably will want that. But I do think that in my mind, that's also, I'm hearing a lot of triggers for that. And so it also, I guess if I were the PA managing, probably connect with my care management team to kind of, and attending to maybe think about having them get involved. I don't know if, Marla or Jennifer, you have any thoughts around that when you guys see these kind of patients too. Oh, Marla, I think your mic might be muted there.
When it comes to patients, especially readmissions, we are looking at them differently to see what's actually bringing them in. And then two, sometimes we connect them hopefully with an ACO management so they can follow them more closely, and also talk to their insurance, because a lot, and especially in this case, we do have the transplant social workers. So he'd be seeing them outpatient, they'd be following the care, but also want to see what all the resources they'd have available to him, insurance-wise, whatnot, community, when it comes to having that extra coverage and then that extra support needed, especially at that age and all these readmissions.
Yeah, I think that's a great point. I think oftentimes we forget about going to the payer with these complex cases. And I think even during the peer-to-peer, sometimes you can talk to the medical director and say, hey, we are having some trouble with this patient. They are in a lot. What additional services and programs do you have? Because I've often found that there are programs that payer has that we don't know about. And if we don't start asking the question, or they have their own complex case manager that you can connect them. And surprisingly, maybe the patient's not already connected with the payers, in those special programs. So I think that's a great point.
I think, great point made, Marla. We are noticing that is changing a bit from what we've seen in years past as far as it relates to care managers that we work directly with those insurance companies. So that's just another perk when we stumble upon that. Not, across the board, but we are finding those in certain circumstances. So always helpful to ask.
No, this is a great case, Sweta.
Yeah, and thanks for valuable input, because I agree, like these, especially high utilization, these patients who require higher resource utilization, it's better to be proactive and looking for all the resources available, not just within the system, but with the payer system, and having those conversations and at least bringing palliative care early on, because we know the studies have shown, unfortunately, or sometimes a lot of patients, when they look back in terms of mortality review, most of the patients don't have palliative care consulted sooner, and it's more closer to they're passing away, that limits their ability to actually use those resources and be more comfortable, and rather having this limbo of round and round. But I agree with you, Rebecca. When I was reviewing, I was going through that thought, and then 24-year-old, it does get a little bit tricky, but we take care of leukemia patients in their late teens, and it's not uncommon or unheard, but usually we are good about getting our palliative care consulted timely. Thanks again, everyone, for your valuable input. Jennifer, you want to go up next with your case?
Yes, thank you. Thanks, guys, for having us today. I did want to kind of start off by level setting, like Marla and the role that she plays here at Loyola Medicine. I know that we have seen complex case social workers at many of the organizations. When I started here over at Loyola, Marla has a paralegal background. Marla has been a social worker for many years. She is honestly pretty masterful at what she's capable of doing on each and every day, which we greatly value her expertise and her knowledge. She's kind of like a private investigator. So there are multiple things that we are trying to be very proactive as it relates to these very complicated discharges, getting risk management and legal on board as early on as possible if we have very challenging situations. Obviously working with APS, DCFS, IDPH, guardianship, we definitely have some great resources in the area with respite care and Loyola Street Medicine. We've also recognized that it's imperative for us to partner up close with patient access and registration, because we are definitely noticing that we are working these very complicated discharge plans, and then we will find out from one of our partners in the community, whether that's a skilled or acute rehab or an LTAC, that says that's not the insurance that the patient has. We kind of stumble upon that. Or we've had cases where patients are maybe 20 something years old and on file they don't have insurance, but Marla has said, well, did you check to see if they're potentially under their family's insurance, their parents' insurance? And look at that. They actually now, yes, they have some type of financial coverage. We've also been working with the revenue cycle team to apply patients for market insurance when we have undocumented patients. And we also work very closely with the consulate and multiple, we're finding different advocacy plans in different countries as well when we're trying to repatriate and, work with them to see what resources are available. So on any given day, we are pulling on those triggers, and it's been very beneficial. We learn something consistently. One other thing I wanted to add is transportation. We have a company called MedLink that actually travels across the entire country, and they take patients from state to state without charging you that fee to come back with no patient in the vehicle. So it's a much better, it's a much lower cost as we're transferring patients across the country, as well as some of the flight nurses that will go to other countries and connect with the respective consulate on the other side in that country. So a lot of different resources that are available that we keep finding out about, and it's benefiting. There are quite a few cases I would love to talk about, but I think, Marla, why don't we talk about our young gentleman who was 30-something years old, and he was traveling across the country from New York, and he was in an accident, and he had multiple burns. So we have one of the, burn units here in the state of Illinois. So he was transferred to us, and he had multiple amputations. He was in our hospital for, I think, close to 200 days. Unfortunately, he happened to be a sex offender on top of it. So he was an extremely difficult placement. He did have insurance. He was very comfortable being in this environment. And honestly, I don't think he had any desire to leave our hospital at any point. Another key thing that we work with our team on a consistent basis is having those tough conversations. Telling patients that when you are medically ready and medically stable to move to the next level of care, we have to move. And a lot of that comes from our care managers and social workers. We do have some physicians that are very comfortable and confident having those discussions, but there's not a lot of people that feel confident to have those discussions. And then they get nervous about what legal ramifications, especially when our patients sometimes pull out phones and want to videotape, or somebody's afraid that somebody's going to call somebody. So I'm going to let Marla talk a little bit about some of the key things that she did to set this patient up for a successful discharge, which was extremely challenging. Go ahead, Marla.
So one thing I want to point out about registered sex offenders, which I had no idea before, is there are some states that there's different levels. So in New York, he didn't have to be on a registry. So he just was being monitored. But in the state of Illinois, regardless of the offense, you're on the registry. So that was a huge barrier because once he was here, he ended up on the national registry. So if he was, and that's a little scary in general for some states that have levels, because you won't know that you have a registered sex offender because they're not showing up on the national registry. He didn't show up in New York at all. He showed up on the national registry. So what he did was we actually finally found a place to accept him. And he called there because it wasn't exactly where he wanted to be. But this was out of, I have to say, 600 referrals sent out, working with, because he wasn't an active parolee or on probation, there's nothing you can do in that respect because the law enforcement isn't going to do anything. And they also kept saying, well, he's not on the registry. His level doesn't meet criteria. Again, his crimes were not, were more internet or, it wasn't a physical crime to anybody. However, to those, whoever it was that were part of that was a physical crime. And he kept saying, well, I never touched anyone, but it really didn't matter on that aspect of it. So he called the facility. We actually had him all set up to go. It was counting, like, oh, this is just great. Sabotage, they called me and said, no, he's on the National Sex Offender Registry, and he had called here, and he basically kind of outed himself to them because he didn't want to go. He was actually going to be in the state about a few hours away, but didn't want to go. So that turned into me having a very frank and pointed conversation. You can't stay here. You can't. You have to find somebody. We've gone all over. This is not anything we're going to do. At this point, any facility in the United States that's going to take you, you're going to go to. Miraculously, he got on Facebook, found 2 people who'd be able to accept him. Again, when it comes to working out of states, here you can set up equipment. It's there the next day. In his home state, that was not the case. You actually had to have training. You had to have all these other aspects of it. Got all that together, got it done in the home. And we had him discharged to the home. So we did have a safe discharge plan for him. What happened once he got there is a completely different story. But I took all the steps to get him to the next level of care. But it really was, but you don't want to have to put your foot down in a sense. But all his sabotage, he was very comfortable here. He didn't want to leave. He was not always the best to staff, and it was going above and beyond to make sure he had a safe plan, which he did, sabotaged it. And then it turned into going to some random person's house that he met on Facebook. But I spoke to them. They were fine with it. They said, oh, yes, we'll take him. And he then discharged there.
I think the other thing to add is we worked with our local ambulance company, and we had to secure a helicopter to take him to New York because the ground transportation would have been too cumbersome and long. He required additional care and, different positioning. So the costs that we incurred on top of that to fly him, to New York City and then transport him to this home. Marla also had to work with the state of New York because that's how they set up home health care. The next morning the home health care team came and called that afternoon and said, we won't be able to go to this house again because it's a drug house. So that then deterred another complicated situation. So, just an example of, honestly, things that people don't really hear of what's happening, and you don't understand the complexity of putting these puzzles together and each of these intricate pieces and how any given situation can derail a very strong discharge plan that takes an enormous amount of time and energy to put together. So when I got this phone call, Marla just came to my mind immediately because I know how hard she works every day and our entire team. And I'm just here to break down barriers and remove those barriers and help facilitate and be creative as we can to move these patients to a safe level of next care.
Yeah, I guess one thing that kind of jumps out to me in thinking about other patients that, I've been pulled into, not exactly the same story, but, some similar elements. And, oftentimes we get a patient that very medically complicated, has had that long stay. We're at the tail end and we're stuck on the discharge. The patients become very comfortable with our level of care. They like it here. They feel safe. And you will see that behavior, as you described, Jennifer, of that self-sabotaging, like they don't want to leave. And so I know it can be so hard for our care management team when you get a plan together and you think, finally, we've got something that's going to work. It's going to be safe. It's the right thing for the patient. And then your patient self-sabotages. But I know one thing that we've had to do with some of these patients, and it's really been at all hands on deck, is pull the whole care team together. Because oftentimes you'll get patients playing staff off of each other. They're trying to manipulate their, I don't know, we've had them ordering in, all sorts of items from a favorite shopping network, or ordering in food, or ordering the nurses to do lots of things for them. They get very comfortable. And so I know we've had to set a lot of boundaries, really get the team together, because setting those boundaries when you've got someone that's can have a strong personality can be hard for that care team. So I think that's one thing I know we found helpful, is when we've had to pull the whole care team together and just had, sit down and say, this is the way we're going to manage this patient. We're going to have a consistent message. We're going to have 2 people in the room at all times. We're not going to allow this or that, or we're going to, set a limit or a goal for this patient. And I know some of those tactics are what we've had to try. Was that part of what you had to do too, Marla, to really get this patient to actually get on board with the fact that he had to leave the hospital? And it sounds like you had to do something to get them to work on their plan and get them to go from, I'm comfortable here and I'm going to sabotage anything you do, to actually working on getting some people to take them in their home.
We have a complex case committee, and so there's once a week we meet, and I'm always following those patients. And I also meet with the physician advisor separately on all long stays. So we go over them. So he's talking to the doctors. So we're always in communication. And I can say it really has helped with our length of stay. When you have 2 people looking at these patients, why are they still here? Then I have my physician advisor calling the doctor, like, what's going on? I've got Marla here. Let's figure out a plan. So we are all working together on these plans. Again, this patient, he had so many obstacles, and I kept saying, like, all right, I'm just going to go over this hurdle. I'm going over it. And then we finally got to that point. And I'm not at that moment. I just remember saying, you're going somewhere. And I had literally for months, every day, sitting there talking to him. He had no one. He didn't have this. He couldn't do that. And that's it. And it was, maybe sometimes people need more of that stern rapport to actually get moving, because at that moment, he found these 2 people on Facebook. Again, I spoke to them. They were fine having him. But prior to that, you go in, being very accommodating, more gentle. And the moment I was like, we're done. Anywhere that's going to take you're going to go to, within 3 hours, I said, I'll be back. I want to know where you're going. He had these people. So you don't, again, that's really not always the norm, but at different times, you're going to have to actually just say, this is how it's going. And
I think that the other thing that we learned is, again, bringing in legal to these situations, because some of our physicians are concerned from a legality perspective to say, you are leaving, you're medically stable, you're medically clear for discharge. And patients will say, I'm not comfortable leaving. I don't feel safe leaving. And, we have to have risk and legal also supporting what we're doing. And sometimes we will have public safety upstairs with us, just so that, to your point, Rebecca, everybody is on the same page. There is no, it's a united front that you will move to the next level of care in a safe manner.
For everything you all have said, because we have had similar patient challenges, and we have what we call advanced case management team as well. So it's a consistent message, small team that's very experienced taking care of these patients. and we meet regularly and have patient experience, because a lot of time they'll call patient relations as well as legal be on board to make sure we have a consistent message. And from someone who is has that registry of sex offense, it does get difficult to place, because when we are placing them in a nursing home where they are more vulnerable patients, we have to keep in mind you're not risking them as well. So somewhere I can see why some of these facilities would refuse to take, and finding group home or other alternatives where they can be safely placed, still get the care, can be another alternative that we've been able to work on.
Thank you, Marla and Jennifer, for bringing that case. Definitely a different case for us, and glad that you were able to share that. I think hopefully our listeners will get some takeaway points from that.
The Association of Physician Leadership in Care Management, or APPLCOM, was created to provide support and education for physicians in this field. APPLCOM is unique because of its connection to the American Case Management Association, focusing on the partnership and collaborative model of nurse case managers, social workers, and physicians in care management. ACMA has a rich 25-year history of supporting the case management field. AppleCom is inclusive of all practice settings. Membership in AppleCom also gives you access to all ACMA resources and benefits. Whether you're new to case management or have years of experience, AppleCom membership is valuable. Gain access to professional networking opportunities and resources. Visit www.applecom.org to learn more. Case managers, join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Access the Member Education Center with recorded webinars, CEs, and peer-reviewed articles 24/7. Visit www.acmaweb.org/membership to learn more.
Okay, well, I'm so glad you guys are all here today. I've got a tough case I need some help on, and hoping to get some different thoughts on this one. So my patient's a 40-year-old female who presented to one of our emergency rooms. She had really no prior medical history. She was working, thought she was well, didn't think she had insurance, so wasn't really going to the doctor much, but presented to our ER with a chest pain complaint. Also was having some like numbness and tingling in the right hand and leg. So in the emergency room, they noted that blood pressures were elevated in the 200s. ER physician evaluated the patient and did a CT scan as part of the complete workup that they did. And ultimately, this patient was found to have a type A aortic dissection that was involving the aortic arch. So really, obviously a very critical patient. They, had surgery evaluate right away. This was, in the evening, right before midnight. Patient did go to the OR very promptly. They did require aortic arch grafting, bypass to the arm, because there was actually clot involved as well to the lower extremity. So a very complicated surgery. Vascular procedure was done, emergently to save this patient's life. Unfortunately, post-op complication occurred within the first 24-ish hours, with the patient having a significant stroke requiring intubation. The patient was, very big stroke, and then not responsive, so needed to be placed on the vent. So fast forward on the case. So patient, we did ultimately find out this patient had insurance. They had a plan that was out of network for us. We didn't know they had it. They didn't know they had insurance. Why that happened, complicated, so we won't go into that. But bottom line is they did have an insurance. So we had a sick patient, still very ill. So early in the stay, we had to manage that out of network denial with the payer. And a couple of things, with this particular pair, we had to really establish the urgency of it. It did require peer-to-peer. You would think that this would seem pretty straightforward, but it did require multiple peer-to-peers to establish the sick, how critically ill this patient was, the inability to transfer this patient. So that was early on. Now, fast forward, we've got a patient that's not decisional. They ultimately were trached. They were able to get off the vent, but still trached, pegged, not really responsive. And this patient is in a state where if you don't have a power of attorney, it does get tricky. We cannot just go to next of kin to make ongoing decisions. So you're kind of stuck. If you can't establish a power of attorney that you can activate, you have to go down the guardianship route. So that is also in the background for this particular patient. So after extubation on this patient, we are both having to manage the patient's out-of-network denial because our payer at this point is saying, well, you could send him to LTAC. You could send them to one of our more complex SNFs that can manage some of these trach patients. And we're not going to continue to pay for this out-of-network patient at your facility. So that's one issue that we had to struggle with on this case. And then second was because we did not have a substitute decision maker on this patient. And we were running into barriers with our family wanting to go after guardianship. I won't go into the details on that, but bottom line is we were kind of stuck on two fronts. We couldn't move the patient. We weren't getting paid for the care. So I'm going to pause there and kind of see, I'd love to hear some of your thoughts, Jennifer and Marla, on how you would work both issues, the denial aspect with the payer, as well as what do you do when you're stuck on that substitute decision maker and not being able to go forward on the disposition.
So one question, was it insurance with an employer or a spouse?
No, it was one of the exchange plans. So yeah.
Okay. So then, after, if they were there for 30 days, were they able to apply for Medicaid, considering her?
Yes, we did have a Medicaid application in the works, but the stay is still going to fall to that exchange plan. So we are still stuck at this point with, they're the payer for this hospital stay. And also we've got a patient who can't cancel that exchange plan, even if they don't want it, because we do have that happen. So we're stuck right now for the payment being that exchange plan.
And then with the guardianship, have you started to pursue guardianship? Or talk to the intake?
Yeah, it's a bit complicated in that we have not as an organization. We do have, family involved as well. There is family. I know sometimes we'll have these patients and they will have no family, no one, or maybe they're undocumented and, families out of the country. And we don't even, we don't have that. This patient does have that, so that it is a complicated situation. So I know one of the things that I heard you guys say earlier is these kind of cases, definitely legal risk, are so important to get involved in. And I don't know, again, where would you go with this case when you're having challenges moving ahead with guardianship? Would you automatically do that as an organization, or would you still try to continue to work with the family to help pursue that?
So when there's family, when there's a family, I can say that I've spoken to the guardianship office more times than not. And what they'll actually do is work with the family to, make sure that they're taken care of. They tell them about grants. They tell them about different funding. They understand. So this isn't the first time they're encountering that. So I would call the intake. They do their due diligence also, but then too, I look at it like, but the hospital doesn't want to be a guardian because, they're financially responsible. But I can say we have a great intake worker here for the guardianship office. You get somebody who understands what's going on, and she'd advocate, she'd talk to the family, she would do these things, she would tell them about different funding for them to be able to, and she would explain the pros and cons of somebody else coming in. So it was having that extra layer for the patient's family to know, look, if you aren't willing, this is what's going to happen. And they will go right to a guardian if the family's not willing to take that responsibility. So having that conversation has been very helpful because in our case, family members will pursue it on their own. I mean, patients will eventually leave, but they're still in contact with the guardianship office. They're still working with legal aid. They're still doing everything to be able to take care of their family member.
Yeah,
it's a good clarifying question. So sure. I think Usually, yes. So if we have a next of kin or decision maker and that guardianship application is in process and someone's not decisional, we can use it in our state as well. But Rebecca, I thought you said we cannot use next of kin for discharge decisions. We have, or for decisions, it has to be DPOA. So in that case, then guardianship hearing has to happen before that person can make the decision. And transferring a patient is, again, has to be a patient decision, right? Because if I'm not wrong, payer cannot dictate that. Two, was the patient even safe or stable for the transfer, right?
Definitely early on, they were not. They absolutely, we had a strong argument for they had to be at our facility. They're critically ill. Then they did reach that stability, but that's where we got stuck. This was both, a lot of social factors as well as a payer issue. And, you can't just send a patient, to another hospital. Now we will use, for making, we don't have that substitute decision maker. If we clearly have involved family, like in the moment of, medical decisions, we will use that if they appear to be acting in the best interest. But when we get into some of these disposition issues, that's where we get stuck in our state of not being able to transfer that patient. We probably could have transferred to another hospital, in-network hospital. If those in-network hospitals would have accepted the patient, they would not, because they saw the dilemmas here, with this case, and they did not want to take the patient. So yes, we probably could have done that if we had an accepting facility. Same thing with an LTAC. Oftentimes our LTACs, when we are in the process of the guardianship process for cases, they will take those patients knowing that, we've got an endpoint, we're going to have a decision maker, we'll be able to get that patient out to, SNF, or long-term nursing home, group home. There's going to be an option for that patient. But LTACs, when we don't have a patient, dispo option, and they can see all the barriers, they don't want to take this sort of patient either. And so that's kind of what we were running into, is because they didn't see a clear guardianship path. I do like what you're saying, Marla, about, your team really talking to the family and figuring out why they didn't want to become guardian, because I think that to me is one of the keys with our particular case, is understanding why, and sometimes it's, we've run into this with other cases where, whoever that significant other is in that person's life that has some interest, sometimes they're like, I just can't be that guardian, and understanding that, or are they worried about the finances of it? Because these can be expensive to pursue guardianship, and maybe they don't know the resources or don't understand it. So I think that to me is one of the lessons from this case too, on the social, is really, when you've got a family potentially putting up barriers and like, why can't we move ahead with this, is really getting to their why. And then I like that you guys have a nice program with that too. Other thoughts, I guess, Jennifer, Marla, or Sweta?
I definitely would recommend calling the Guardian office to just put it on their radar. I mean, they do a great job doing investigative work to support what we need all the time. And then it also allows them to make sure that whomever it is making the appropriate and best decisions for the patient. Because if they do need to assign a guardian ad litem and not go for full guardianship, they can still make decisions appropriately for the patient. And sometimes this takes a long time. So patients can be placed at a skilled or at an LTAC while that whole investigation is going on, and further long-term decisions can be made. But our goal, obviously, we know in the acute care setting, is if they don't require this level of care and this cost in taking up one of these beds, right, we want to move them to the next place to then allow for that investigation to close out. And then again, to the point we made earlier, when these things happen and we know we're kind of stuck, I definitely feel very confident and comfortable calling our attorneys and just saying, can I put this on your radar? Can you think of anything else? What rights do we have as an organization? Obviously, keeping the patient center at all times, and safety and their needs. But we do run into a problem where sometimes it's like we feel we're at a loss of patients can't live here. They can't physically live here in the hospital, so we have to keep pushing forward in leveraging each of those resources to see if somebody else can support it.
Yeah, and I think one of the other points I wanted to make with this case is on the denial aspect of it. The way our system's structured, those frontline peer-to-peers usually occur with our site physician advisors. And, they definitely did multiple peer-to-peers on this case. And then we hit that roadblock of like, you can transfer the patient, we're not going to approve it. And that for me was the other, I think, take home point in this case is that these are special cases. All of us are going to have these cases at some point, maybe multiple cases a year, depending on your facility. But you have to, I don't think that no initially that you get like, hey, we're not paying for this should be the end of the discussion with the payer. Like for me, this scenario, and we have variations of this all the time, partial stay denials from a payer saying, well, you could discharge them. It really need to be escalated. If you can't get it overturned into frontline peer-to-peer, for me, this is the kind of case I usually take to our managed care part of our organization to have that higher level discussion within the payer, within our, contracting folks. And oftentimes for us, these cases can turn into like single case agreements. Sometimes we will agree, yes, this could be provided at a SNF level or LTAC or something that's lower than our hospital. And we have to work on that single case agreement to help get it paid. But we shouldn't just be on the hook for all the cost of this patient's care. This is a complicated patient. They can't live out in the streets. They've got ongoing care. And, and we have been successful with that tactic on other cases that have the story is always a little different, but a similar flavor where you can't discharge them. So I don't know, to me, that was one of the other things. I don't know, any thoughts from the rest of you on the...
I want to add to that, like sometimes putting the onus on the payer has helped too during those discussions. Like if we hear you that you want us to transfer this patient to the in-network hospital, and we made the attempts and showed that we did make an attempt, but those facilities are not accepting. So if we don't have an accepting facility that has the ability to take care of this patient, then it's hard for us to transfer unless they want to reach out, and then sometimes having their complex case manager be involved. We've been able to, especially like we've had some patients who are drug abusers or IV drug use who need long-standing IV antibiotics, and then showing that we've applied or sent to hundreds of SNF or SARS to try to get this patient transferred, but no one's accepting is not something in our control. So we have to keep the patient to complete the treatment, and why they need the IV has been helpful. And a lot of times, like I said, they would then add their complex case manager too. And if their case manager also fails to find the placement or transfer, that has been a huge help in making them accept that it is the need for coverage in the hospital for this patient.
So just to, on that point, we do end up, because we end up getting a lot of IV drug users. Once we do exhaust that, a lot of LTACs will take them. So look at that option, because we will get them in. I know the moment I know that there's an IV drug user, no SNF's going to take them. We do our due diligence. We send out all the referrals. Then they end up going to an LTAC. And so then again, that moves them on to the next level of care. That's been very helpful here.
Absolutely. It's just like, I know if I'm not wrong, but for LTACs, for Medicare and Medicare Advantage plans, they need the 3-day ICU stay or that high or moderate level of care coding. Not a lot of them have. And generally, along with the IV antibiotics, like two nursing needs that would qualify them for LTAC. That has been a lot of times another barrier in transferring. But we do think about LTAC, especially if someone needs a long course of antibiotics, for sure. We try to push them.
I think one other thing that we definitely do a good job at, I believe, is escalating these type of situations to the IHA. They want to hear about these situations where insurance companies are pushing back and denying. And whether they do something in real time or not, they are always looking for examples from us to help support what we're doing. So that might be something too, Rebecca, to take this case and, summarize it and let them know that this is what you're struggling with, because the more that they hear about these situations, the more I think that they'll be an advocate and support the hospital side.
Yeah, no, I think all great points when we get stuck with these, challenging cases, both socially and from that, getting that payment source for the care that medically necessary care that these patients need. So I love, thank you so much for all the, great ideas around this case. Hopefully our readers or our listeners will get some takeaway pearls to help them with some of these similarly challenging patients. So thank you all for coming today.
Thank you to everyone for joining us for another episode of Case by Case. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so that you are notified when we upload new episodes. Until next time, this was Care Transitions Today, Case by Case.